Good morning, good afternoon, and good evening. A month ago, I convened the emergency committee under the international health regulations to assess whether the multi-country monkeypox outbreak represented a public health emergency of international concern. At that meeting, while differing views were expressed, the committee resolved by consensus that the outbreak did not represent a public health emergency of international concern. At the time, 3,040 cases of monkeypox had been reported to WHO from 47 countries. Since then, the outbreak has continued to grow, and there are now more than 16,000 reported cases from 75 countries and territories and 5 deaths. In light of the evolving outbreak, I reconvened the committee on Thursday of this week to review the latest data and advise me accordingly. I thank the committee for its careful consideration of the evidence and issues. On this occasion, the committee was unable to reach a consensus on whether the outbreak represents a public health emergency of international concern. The reasons the committee members gave for and against are laid out in the report we're publishing today. Under the international health regulations, I'm required to consider 5 elements in deciding whether an outbreak constitutes a public health emergency of international concern. First, the information provided by countries, which in this case shows that this virus has spread rapidly to many countries that have not seen it before. Second, the 3 criteria for declaring a public health emergency of international concern under the international health regulations, which have been met. Third, the advice of the emergency committee, which has not reached a consensus. Fourth, scientific principles, evidence, and other relevant information, which are currently insufficient and leave us with many unknowns. And fifth, the risk to human health, international spread, and the potential for interference with international traffic. WHO's assessment is that the risk of monkeypox is moderate globally and in all regions, except in the European region, where we assess the risk is high. There is also a clear risk of further international spread, although the risk of interference with international traffic remains low for the moment. So in short, we have an outbreak that has spread around the world rapidly through new modes of transmission about which we understand too little and which meets the criteria in the international health regulations. For all of these reasons, I have decided that the global monkeypox outbreak represents a public health emergency of international concern. Accordingly, I have made a set of recommendations for 4 groups of countries. First, those that have not yet reported a case of monkeypox or have not reported a case for more than 21 days. Second, those with recently imported cases of monkeypox and that are experiencing human-to-human transmission. This includes recommendations to implement a coordinated response to stop transmission and protect vulnerable groups, to engage and protect affected communities, to intensify surveillance and public health measures, to strengthen clinical management and infection prevention and control in hospitals and clinics, to accelerate research into the use of vaccines, therapeutics, and other tools, and recommendations on international travel. The third group of countries is those with transmission of monkeypox between animals and humans. And the fourth is countries with manufacturing capacity for diagnostics, vaccines, and therapeutics. My full recommendations are laid out in my statement. I thank the Emergency Committee for its deliberations and advice. I know this has not been an easy or straightforward process, and that there are divergent views among the members. The international health regulations remains a vital tool for responding to the international spread of disease. But this process demonstrates once again that this vital tool needs to be sharpened to make it more effective. So I'm pleased that alongside the process of negotiating a new international accord on pandemic preparedness and response, WHO's member states are also considering targeted amendments to the international health regulations, including ways to improve the process for declaring a public health emergency of international concern. Although I'm declaring a public health emergency of international concern, for the moment, this is an outbreak that's concentrated among men who have sex with men, especially those with multiple sexual partners. That means that this is an outbreak that can be stopped with the right strategies in the right groups. It's therefore essential that all countries work closely with communities of men who have sex with men to design and deliver effective information and services and to adapt measures that protect the health, human rights, and dignity of affected communities. Stigma and discrimination can be as dangerous as any virus. In addition to our recommendations to countries, I'm also calling on civil society organizations, including those with experience in working with people living with HIV, to work with us on fighting stigma and discrimination. But with the tools we have right now, we can stop transmission and bring this outbreak under control.
So since the beginning of this outbreak, WHO has been in regular contact with the manufacturer of these medical countermeasures, including with member states who previously has made national stockpiles of smallpox countermeasures available in their national stockpiles. And from these discussions, we know and have an understanding of some of the countries that have access and the global supply situation. I think first, when we look at the demand situation of one of the countermeasures, the MVA-BN vaccine, we know that from the countries that are reporting cases at the moment, roughly half of them have already secured access to this vaccine. For those other half, we don't know for the moment. We have some information that some of them are in discussion with the manufacturers to procure this vaccine. At the same time, WHO continues to discuss with member states that holding larger stockpiles for solidarity in sharing and donating vaccines to those that don't have access at the moment. So this is an intense effort WHO doing is at the moment. Secondly, on the supply situation, we have been discussing with those manufacturers what is available in 2022. We have a rough understanding about the 3 vaccines that are existing at the moment, are being mentioned in the WHO interim guidance for immunization. So on the MVA-BN vaccine, we do know that at the moment, 16.4 million doses exist in bulk, which means they require fill and finish. We have roughly 1 million of those are already in fill and finish situation. On the other 3rd generation vaccine, the LC16 in Japan, we know from the manufacturer that this is only being produced for the government of Japan, and we have good discussion with the government of Japan how to make some of these accessible to other countries. And thirdly, on the so-called 2nd generation vaccine, ACAM2000, we know that roughly 100 million doses of this vaccine exist with various member states in their national stockpiles. So this is the supply situation in 2022, and we're evaluating with the manufacturer what will be more available in 2023, and these are ongoing discussions. I would like to underline one thing that is very important to WHO. We do have uncertainties around the effectiveness of these vaccines because they haven't been used in this context and in this scale before. And therefore, we are calling and working with our member state that when these vaccines are being delivered, that they are delivered in a context of clinical trial studies and prospectively collecting this data to increase our understanding on the effectiveness of these vaccines. Thank you.
欧米などで感染が拡大しているサル痘について緊急事態が宣言されました。
緊急事態宣言って聞くとちょっとドキッとしてしまうんですが、私たちはどう受け止めたらいいでしょうか。
そうですよね。サル痘に詳しい岡山理科大学の森川先生に話聞いたんですが、ワクチンもなかった新型コロナとは違うんだと、サル痘はワクチンも治療薬も世界に承認されたものがあるとおっしゃっています。サル痘はですね、1976年に接種が廃止されました天然痘のワクチンが有効だとされています。でそのため今、日本の厚生労働省は接種の準備急いでいるほか、国内では未承認、承認されていない治療薬をすでに確保しているということだそうです。
ただ未承認ということは、もし感染しても接種できないということなんでしょうか。
私も未承認だからそれはダメだと思ったんですが、実は使えるんですね。どういう仕組みかというと、この治療薬はアメリカのメーカーが開発したテコビリマットという薬、天然痘を治療するための飲み薬なんですが、厚労省は今後ですね、日本国内で感染者が出た場合には、この薬を特定臨床研究の枠組みで投与できるという仕組みを作ったんです。有効性とか安全性を調べるという名目のもと、例外的に使えるようにしたということなんですね。ですからこういう仕組みも一つ安心材料にはなるんではないかということです。一つ安心材料にはなるんではないかと。一つ安心材料にはなるんではないかと。